I'm going to talk about lung cancer screening. We've been talking about lung cancer, and this is the way to try and cut down on the number of people who suffer with this disease and die from it. Obviously, I want to get people to quit smoking, and that's going to take care of it, but that's 20, 30 years down the road. And what do we do until then? I had a question earlier today about, well, we screen for colon cancer. Why don't we screen for lung cancer? Well, I'll start with a quote from Dr. Molsheim, who was one of the investigators in the recent lung cancer screening trial. And he says that the opportunity to realize that lung cancer screening now presents us with the opportunity to realize the greatest single reduction of cancer mortality in the history of the war on cancer. More than any other drug, more than any operation, more than any other discovery in our war on cancer, lung cancer screening will save more lives. Now, why should we do lung cancer screening? You've heard all about it today and how advanced lung cancer is a bad thing and early lung cancer is curable. You heard from Dr. Hunis this morning about the statistics, which I just want to remind you about. It's the #1 cancer killer and the #2 killer behind only heart disease. So if we can cut down on that, that would be great. And you saw numbers like this in the morning, where the number of deaths from lung cancer far exceed that of breast cancer, colon cancer, pancreas, prostate, and so forth. But the reason I'm showing this slide is that we have screening tests for colon cancer, we have screening tests for breast cancer, we have screening tests for prostate cancer. So 3 of these 4, we now have screening tests, but not lung cancer. There's that survival by stage number and the proportion that present with advanced disease. What we want to do is shift these numbers. We want to stage shift. So all these patients are now picked up when it's a stage 1 or stage 2 cancer. Well, why haven't we had screening up to now? Well, chest x-ray studies turned out not to show any benefit. We looked at sputum cytology, cough up some sputum, look at it in the microscope. That turned out not to be effective. And then about 10 years ago, people started looking at the CAT scan. We've shown you lots of pictures of CTs, and we talked about how it's so sensitive, it can pick up little tiny nodules. So you would think that a CAT scan would be the way to go. And it's taken us a long time to figure this out. The big study that looked at chest x-rays was from the Mayo Clinic. And this was kind of a summary or a revision of, revisitation of that study. And it was a randomized trial that took active smokers, around 9,000 men who were heavy smokers between 1971 and 1983, and randomized them to get a chest x-ray with sputum every 4 months or chest x-ray with sputum once a year. And you would think that a chest x-ray would be a great screening tool, that you would pick up more cancers earlier. And this is what they saw. On the upper left is the survival curve. So we've shown you survival curve. Remember, as the curve falls down, that means more people are dying. So we want to see this curve stay up really high. And this is the survival curve. So those who got a chest x-ray every 4 months, up here. Those who got it every year, down here. So this looks great, right? The people who got the chest x-ray every 4 months had a higher survival than the ones who got it every year. These were the percentage of patients with lung cancer, not the overall population, but the people who were diagnosed with lung cancer, their survival rate. But if you look at the graph a different way, the number of people dying from lung cancer, depending upon the number of years as the study progressed, the curves were overlapping. How can that be? How can you have more people surviving in this group, but the number of deaths being the same? If you look at the stage of the patients who were diagnosed with lung cancer in the study, and we graph it between resectable or unresectable, or early stage or late stage disease, the patients, this is the control patients who got an x-ray every year, so most of them in the unresectable category. And then we look at the ones that got a chest x-ray every 4 months, you see a lot more cancer diagnoses. But what's critical about this slide is the difference is all here. In other words, we didn't shift anyone from advanced disease. We didn't pick up any of these advanced disease patients at an earlier stage. All we did was pick up a bunch of early stage disease. And the problem with this, which I'll get into later, is what's called overdiagnosis or lead time bias. Maybe these patients never would have died of lung cancer. maybe that's the problem. Maybe the reason we're not seeing a benefit is because this is overdiagnosis or a lead time bias. Another very large study of lung cancer screening is actually a study of multiple cancers, prostate, lung, colon, ovarian. This one contains about 150,000 patients. Annual chest x-ray versus usual care. Same thing. The control group, the screen group, almost identical in terms of the advanced stage diagnoses. More patients diagnosed with early stage. We don't see a stage shift. We want to see these numbers go down. We want to see this yellow bar go all the way down here. That's how we're going to achieve benefit. And so that's why these studies didn't really work. See, if you look at the number of lung cancers detected, pretty much the same. The two curves overlap. Number of deaths overlap. So in 1999, LCAP was published, the Early Lung Cancer Action Project, where they took 1,000 people, smokers, they did CAT scans for them and said, look, we found all these early stage lung cancers. See? We found 23 stage 1 lung cancers and only 3 advanced stage lung cancers. And when we did a chest x-ray, we didn't find nearly as many early stage lung cancers. So this is great. Well, of course, the objections were quite early on and vocal. Well, this looks just exactly like the data from the Mayo Clinic. You're not doing any stage shifting here. You're just picking up all these early lung cancers. How do we know that's actually going to make a difference in survival? Remember, those two curves in terms of the number of people who are dying were exactly the same between the two groups. Is this a question of overdiagnosis? In other words, are we picking up little cancers that maybe are very indolent, they're very slow growing? The guy would have died from his heart attack or would have been hit by a bus before he ever would have died from his lung cancer. The lung cancer is not a serious problem in this particular patient. I know it's hard to believe, but that's the concept. Is this overdiagnosis? Or is this another problem called lead time bias? What do I mean by lead time bias? So imagine you've got Stan here. He's a smoker. And he enters into a lung cancer screening program. And he gets a chest x-ray or chest CT scan that picks up a little tiny cancer there. All right? So that's picked up here about the 5-year mark. And he gets treated. And he gets his lobectomy. And he does really well. But not everybody who gets surgery for lung cancer survives. Some of them get a recurrence of their cancer. And a couple years later, he gets a recurrence of his cancer. He now has a malignant pleural effusion, and a year later, he dies from his disease. So he's had a survival of about 5 years. Okay? Well, Stan has a brother. Stan's brother smokes. He's a twin. Same genetic risk factors, same smoking history. And he just goes about his business, and he says, I don't need any of that screening. I'll be fine. Lo and behold, one day he shows up with a malignant pleural effusion. He diagnosed with lung cancer, and he survives a year and dies. So what's happened? Both men died of their lung cancer at the exact same time. This man had a 5-year survival, and this man had a 1-year survival. So if you look at the survival, we've done a great job by screening. Right? That's called lead time bias. And that's the problem with screening studies. We've gotten a 3-year survival advantage just by doing our screening study, even though we've had no impact on the actual mortality from the disease. So as a result of all this information, the United States Preventive Services Task Force concluded, and this is the organization in the federal government arm that is tasked with the job of deciding what kind of screening studies to do and population health research. So in 2004, they recommended, they said that there's insufficient evidence to recommend for or against screening asymptomatic patients. So this is after those early studies of CT scans. They said, look, they look great, but you haven't proven a benefit in mortality rates. So we can't recommend CT scanning. Well, a lot of people believe very strongly in this, and were able to convince the NIH to fund it to the tune of $300 million. This is the National Lung Screening Trial. It was published in the New England Journal of Medicine in 2011. Enrolled patients at 33 different sites around the country, randomized to a chest x-ray or a CT scan. So patients were aged, well, not patients, just individuals, were aged 55 to 75, significant smoking history, greater than 30 pack years, and they had to have been an active smoker or quit within 15 years. And they were enrolled in a program where they were randomized to either get an annual CAT scan or an annual chest x-ray. So it enrolled about 53,000 people, split between the two groups. and then they followed over time what happened. They had a very strict protocol about how to follow up on the results and what was considered a positive test and what was considered a negative test. Well, these kinds of studies have a precaution built into it called the Data Safety Monitoring Board. In other words, if you're running this study and it looks like one treatment is really better than the other one, you have to stop the study, right? It's unethical to continue to enroll patients in the arm of the trial that is inferior. So periodically you have to look at your data, evaluate how you're doing, and decide whether or not it's actually working. And if it is, you stop. And that's what happened. They had set a threshold for looking at a 20% reduction in mortality as the cutoff point. And when the Data Safety Monitoring Board met, they concluded that that's exactly what they were seeing, and they had to stop the trial early. So they published the results, and the results showed that the CT screening of these high-risk patients reduced the death rate by 20%. 20%, that's an enormous number. That is so large of a number that if you look at all of the patients screened, all 26,000 in that group, the overall mortality rate in that group was down by almost 7%. Okay? That means that lung cancer was such a large cause of death in that group that by reducing the number of deaths from lung cancer, you could actually see that across the entire population. That's an enormous difference, and that led to a number of changes which we're now finally seeing come to fruition. So these are the two graphs that I showed you to compare to the previous one from the Mayo Clinic study. The top one is the cumulative number of lung cancers picked up. So in the CAT scan group, of course, we're picking up a lot more lung cancers compared to the chest X-ray group. But remember, the Mayo study saw the same thing. This is the difference, the cumulative number of deaths from lung cancer. And as the study progresses, the cumulative number of deaths in the chest X-ray group continues to rise faster than the number of deaths in the CT group. Now, it's not a panacea. There's still people dying from lung cancer in the CT group, but the difference is getting larger with time. And in the Mayo Clinic study, remember, these two curves overlap. So this is what made this difference. This is why this study made such a big impact on the field. Remember the bar graphs I showed you? This is what you want to see. Here's the chest X-ray group, advanced stage, early stage. Here's the CT group. The advanced stage group is smaller. The early stage group is larger. So we've now shifted. We've stage shifted. Some of these advanced stage patients are now picked up with early stage disease, and that's why we're seeing the improvement in survival and mortality rate. Now, just some other statistics from that study. These are high-risk patients. You do a CAT scan, a lot of them are going to have abnormal findings. So the prevalence scan, when they first come in and have their first CAT scan, turns out more than a quarter of them, almost a third, are going to have some abnormality on their CAT scan, a little nodule, a little spot. A very small percentage of those are going to be cancer. Okay, so most of them are not going to be cancer. Small percentage will be cancer. And then when they come back, if they had a negative scan, they come back to their next scan a year later. This is now called the incidence scan. No longer prevalence. You're no longer looking at the whole population. Now you're looking at whether or not something appears in an individual over time. That's called the incidence. So about 17% of them now have an abnormal finding. About 5% turn out to have cancer. So slightly higher incidence of cancer because now you're looking at nodules that have developed in the interval of that 1 year. So it's more likely that those new nodules will actually be a cancerous nodule. So that's really important. The incidence of lung cancer was 645 per 100,000 person years. That doesn't sound like a lot. And it's not. But this is a high-risk group. And in fact, the percentage of positive findings was fairly small. The percentage of positive findings that turned out to be cancer was very small. The vast majority of abnormal findings were not cancer. So when somebody goes in for a CT screening and they find they have a lung nodule or 2 lung nodules or 3 lung nodules, most likely it's not going to be cancer. And that needs to be kept in mind because all these people can't be rushing off to see me and expect me to cut things out. Great for my job, but not so good for business. Not very good. So that wasn't the end of it. A group of actuaries, the people that work for insurance companies and decide whether the insurance companies should pay for something or not, looked at similar data, not the data from the lung screening trial, but from another screening trial. to find out whether it was cost effective. It's great, okay, maybe we're going to save some lives, but is it cost effective? They did a number of calculations based on modeling and looked at cost of treatment and divided lung cancer patients into 3 different categories: early stage, kind of intermediate, and advanced, and estimated how much it costs to take care of them. It's much more expensive to take care of people with advanced stage disease than people with early stage disease. So if you can pick up someone earlier, not only does it cost less to take care of them, but they continue to be productive in the workforce, and so economically it's kind of a no-brainer. It costs less. But what about the cost of the scan? If you factor in having to pay for the scan and then all the tests and so forth, that's spending a lot of money. How much is it going to cost the insurance company to cover all that? And they compared it to some other things that they do. So for example, providing pap smears for every policy. If they're going to give every one of their clients, their customers, access to pap smears, then they have to charge an additional $1.10 per month per policy holder across the board. For colonoscopy, it's about $1 a month more. For mammography, it's about $2.50 more per policy per month for all of their insured. And they estimated if we were going to provide this CT screening, it would only be 76 cents per policy per individual. So very cost effective in the terms of the expense, in terms of the additional insurance money. And then if you look at the dollars per life year saved, which is kind of how the jargon works now at the federal government level and health policy issues, if we're talking about implementing something new, how much does it cost for what kind of a gain? Dollars per life year saved. So the cost of providing pap smears is about $50,000 for every life year saved. Colonoscopy about $19,000 for every life year saved. Mammography about $31,000 per life year saved. And they estimated that depending upon different assumptions, it could be with lung cancer anywhere from $11,000 to $26,000 per life year saved. So compared to our other screening tools, certainly very economical and affordable and makes sense. All right, so what are we talking about? You saw this picture. It's a single breath hold study with no IV contrast. When I talked earlier about staging, I was talking about a dedicated diagnostic CT with IV contrast. This is a spiral, low-dose CT, no IV contrast. You walk in off the street, you take off your shirt, you lay on the thing, and 30 seconds later you get up and you go home. It's a very fast scan. You don't have to get an IV or anything. In terms of the radiation dose, it's about the same amount as a mammogram, slightly more than a mammogram, and it's less than a lot of other common tests, and it's less than living in Colorado. All right, so who's eligible for screening? Well, there are a number of different organizations that have come out with guidelines, and all of them are pretty much based on that national lung screening trial. The idea is they have to be in an appropriate age range, 55 to 70, 55 to 80, something around there. Smoking history, greater than 30 pack years, greater than 20 pack years with risk factors and so forth. And they need to quit smoking within the last 15 years. If you quit 20 years ago, they consider your risk low enough that you would not benefit from having a screening study done. How often? And what do? Well, you get your annual low-dose CT scan, and if you have a negative study, nodule less than 4 millimeters or no nodules, you get another one in 1 year. Easy. If it's greater than 4 millimeters, then you got to think about what to do. Well, maybe you need to repeat the scan in 6 months. If it's real small, repeat the scan in 6 months. Not a big deal. Don't worry about it. We'll see what it looks like. A little bigger, well, then we should probably wait just 3 months to repeat it. The idea is you want to see if it's changing or growing or stable. If it's stable, then you go back to 6 months and then back to every year. But if it's growing, surgery is probably the way to go. If it's growing, it's probably a cancer and it ought to come out. Now, sometimes these nodules are very central and they're very hard to find, and that may pose problems from a logistic standpoint. But the concept is that if you see a nodule that's growing on a 3-month follow-up, that's the patient you need to pay attention to. If it's larger than 8 millimeters, then they recommend a PET CT. Now that's not necessarily universal, and I talked earlier today about some patients in which maybe you don't even need a PET CT, you just go straight to surgery. So you don't always need a PET CT, but that's very helpful. And if it's negative, and your suspicion is reasonably low, then you can repeat the scan in 3 months. If it's positive or your suspicion is high, then you need to start thinking about a more advanced workup or potentially surgery and taking out. So it's a fairly straightforward algorithm for trying to decide which of those patients go on to further study and which ones don't. Because remember, 96% of those findings are not cancer. We want to do interventions and operate and take care of that 4% and leave that 96% alone. So in 2004, they said the evidence was insufficient. Now we have a $300 million study with 50,000 people. And they said, gee, maybe now there is enough evidence. So in July, they published this draft recommendation saying we've looked at all the evidence and we think we probably should be recommending it for the right category of patients. And then December 31st, I just heard Dr. Penzel show the same article, they published their formal recommendations. They now recommend screening CT for people at high risk, and that's that group 55 to 75 heavy smoking history. So now that it's been recommended by the United States Preventive Services Task Force, probably within a year or so, we will see it covered by Medicare. Many insurance companies are starting to cover it here. Memorial, we cover it. So it's now a covered benefit for people who are at risk. It is a free scan for the patient. Now that's not the end of the story. This is only a month ago. But a couple weeks later, this came out. The American Academy of Family Physicians came out with their recommendation saying, you know, it sounds an awful lot like the U.S. Preventive Services Task Force. Evidence is lacking to support or oppose low-dose CT screening for lung cancer. In other words, hold on a second, we're not so sure we agree. Well, if you read what they say, it makes a lot of sense. And their concern is, first of all, we looked at the recommendations, and we're concerned that they're making this recommendation based on one study. Usually, we like to see a bunch of studies and do a meta-analysis and think about this and then see that the evidence is overwhelming, and then we make a recommendation for doing something like this. After all, we're talking about doing CAT scans for a lot of people. This is a lot of stuff we're talking about doing. So maybe just one study isn't going to be enough. I think that's a reasonable objection. My concern, however, is, first of all, it may have been one study, but it was a really big study, and it was really well done, and I guarantee that no one is going to be able to repeat that study, because I don't think anyone would consider it ethical to repeat a similar study like that. Now that you have the strong evidence, who's going to be willing to enroll patients in a non-CT arm? But they go on to say, look, really the problem is that there are risks associated with any screening test, right? There's going to be a considerable amount of testing that's going to be required, including some biopsies and bronchoscopies and other procedures, and all of these have their attendant risks, right? 96% of these findings are going to be negative. We're going to be doing bronchoscopy and surgery and all this stuff on all those people. We're going to see complications and maybe even some deaths in patients who never should have had any of this done if they hadn't had a screening CT. So maybe it's not such a great idea to go out there and screen everyone. It needs to be a shared decision between the patient and the provider regarding the benefits and the potential risks. And lastly, and here's the key, when you're talking to these high-risk patients, don't forget to address the elephant in the room. You can't have a screening program if you don't also have a smoking cessation program. Okay? It doesn't make sense to screen people if you're not helping them to quit smoking. Because that's really where the rubber meets the road. That's where you're going to gain an awful lot. So if you just, hang up your shingle or put your billboard up on 595 and say, we now offer screening, well, that's great, but really you need to have a smoking cessation program as an integral component. So the bottom line, lung cancer screening, the data really are overwhelming, that done well and done properly, it will save lives and save a lot of lives. But it needs to be done in a well-organized program by people who know what they're doing and who are comfortable making decisions about who needs to get further testing and who doesn't, and who are able to do the testing and further interventions with a fairly low, acceptable degree of risk and morbidity. Right? So we don't want the 96% of negative, false positive studies to turn into complications and risks and expense. So you need to do it in conjunction with smoking cessation. So let me go back to the beginning. It provides us with the opportunity to realize the greatest single reduction of cancer in the cancer mortality in the history of the war on cancer. So with that, I'd like to conclude the day. Actually, I guess this is it. I hope you've learned some things and come away with a better sense for what happens to these patients whom you may not see for more than 30 minutes during the day, and help with family members and patients.